Good evening and welcome to In Focus, the monthly live panel discussion brought to you by the Barbados Government Information Service. I'm your host, Sharifa Medford-Gilkes. Tonight, we turn our attention to a matter that could touch every Barbadian family: emergency healthcare delivery at the Queen Elizabeth Hospital. With increasing patient demand and growing public concern about wait times and access to care, we are taking a closer look at how the system is responding, what challenges remain, and what solutions are being implemented to improve patient outcomes. Joining us for this important conversation are Minister of Health and Wellness, Senator Lisa Cummins, Chief Executive Officer of the QEH, Neil Clark, and Head of Accident and Emergency, Dr. Anne-Marie Cruickshank. Now remember, this is a live discussion and we want to hear from you. So send in your questions and comments via the BGIS YouTube channel and Facebook page, and we'll try to get to as many as possible. Ladies and gentlemen, thank you so much for being here with us.
Thank you.
Thank you
for
very
having
much.
us.
And we know it's going to go quickly because we have a lot of questions already pending. So Minister, I'm going to throw the first one to you. Let's go right into some of the operational challenges affecting the accident and emergency at the QEH and how we're addressing them.
So thanks, Sharifa. Thank you for having me, having the members of the QEH team here. Let me start first by saying that the QEH is symptomatic of a broader problem. The accident and emergency room is kind of like the waiting room of any office that you go into. If everything else before you get there and everything else after you get into that waiting room isn't running smoothly, then the accident and emergency room, like that waiting room, is going to have extended wait times. So what we have been seeing so far, and I've been spending, as you know, as I said when I first came into this ministry, time just listening to everybody, listening to the staff, listening to the members, the public who've been making comments in all the different fora, listening to the officers who work in the QEH, whether it's the orderlies, the janitors, the custodians, the laundry teams, whoever they are, just listening. And what I hear from everybody in the polyclinic system, in the private healthcare system, internal to the Queen Elizabeth Hospital and on the wards, is that we are having obviously an aging population on the one hand. People are getting older. They're having more and more NCDs. And so by the time oftentimes people present to the accident and emergency room, you have persons who are sicker. And on the other hand, you have persons who, because they don't have access or they don't go to the polyclinic in time for something that really ought to have been dealt with before it becomes a genuine emergency, they're coming into the Queen Elizabeth Hospital. So that's the input. What goes in has to stay in or come back out, right? So you have to be able to get people through the QEH system, and I think that Dr. Cruickshank will speak about what the A&E system looks like. But we also have another issue, which I think we've spoken about. The QEH has put out any number of bulletins on. We're not getting the output coming from the hospital. We have a number of persons, we have persons in the hospital who've been there for over 100 days, and there's nothing clinically or medically wrong with them, but they just have nowhere else to go. Those persons who we may call anecdotally abandoned, but there may be any number of reasons why they're there, the absence of beds is also compromised, or rather it is compromised with the ability to have greater access to beds. It's compromised by the fact that those persons are taking up beds when there's nothing medically wrong with them and they can be discharged from the Queen Elizabeth Hospital. Sometimes that number can hover around 450 like it does right now. So you can't get through the emergency room if you're sometimes coming in really late and you need to have further access, but you also are stuck in an emergency room if persons who have no reason to be on a ward and in a bed isn't being discharged. So it's an input and an output challenge. And I think that when somebody comes into the hospital and it's their loved one who is not well, none of that matters. You don't care about any of that. You just want your loved one to be seen. And I think that's where Dr. Cruickshank and her team are navigating the challenges that are operational. But I wanted to just frame it a little bit and to put it into context, and not to mention the fact that we do have shortages. Yeah, when I say shortages, I mean they're human resource shortages. There are not enough emergency room doctors at times. There are not enough nurses. And so we have to be able to pull the entire ecosystem together to make it work, so that when people present in that waiting room of the emergency room in the worst moments of their lives, that they're able to get through the system and to be seen.
Thank you very much for putting that in context for us. Dr. Cruickshank, and she would have alluded to your position there. Can you tell us then how the triage system works and how patients are prioritized when they do come into the accident and emergency department?
Okay, so we have a system called the Canadian Triage Acuity Score, CTAS, and there are 5 categories. So when a patient comes in, obviously after being registered, they will then proceed to the screening nurse or the triage nurse. That person, be it male or female nurse, will look at both objective and subjective criteria to give you a CTAS score. So you would start with the presenting complaint. Why are you here? Right? So that's the subjective criteria. But objectively, the nurse has to do the person's vital signs. You know, blood pressure, pulse, temperature, respiration, oxygen saturations, blood sugar, etc. So from the presenting complaint and from your vitals, the nurse, who is a senior nurse, because the triage nurses are trained as triage nurses, they will use the CTAS program to guide them on what triage category. So as mentioned, there are 5, and category 1 is resuscitation. You do not wait, you go straight into the resuscitation room because it's a matter of life and death for category 1s. Category 2s are emergent. Their vitals are abnormal. They need to be seen as soon as possible. Ideally, CTAS says within 15 minutes, but in reality, we may not make that, but we do try for category 2s. Category 3s are persons whose vitals are stable, but they have the potential to become unstable. And CTAS says we should see those patients within 30 minutes. Category 4s are what we call the walking wounded. They're stable, and they can wait to up to maybe 2 hours to be seen. And 5 are quite stable. They're review clinics. They can even be referred to the 24-hour clinic across the street at Sir Winston Scott. So depending on your triage category or your acuity scale, you are seen accordingly.
Okay, so you note the persons that would be not as emergent as others.
Right.
And Minister would have alluded to the polyclinics.
Yes.
Is it a matter of persons not understanding that they can go to the polyclinics to be seen for certain matters and not rush to the QEH?
I think it depends. Some people do feel very comfortable and confident in the Queen Elizabeth Hospital. They do know that all the facilities and services are provided at the hospital, and they would say that if they know that because of their medical condition, they feel more comfortable coming to the QEH because the polyclinics have not been equipped fully in terms of the lab services and radiology services. So they know that they in their mind think, I'm going to need an x-ray, I'm going to need a CAT scan, I'm going to need blood tests. So they come to the Queen Elizabeth Hospital.
Okay, understood. Mr. Clark, good night.
Evening.
Good evening. Thank you for being here with us. Can you tell us about some of the operational challenges that are being faced that are affecting the emergency services, emergency healthcare at the QEH?
Yes, of course. So the Minister alluded earlier to what we need to do to stop people coming to the A&E department who don't need to be there in primary healthcare. So preventing illness and then providing services local to where they live to save them having to come into the A&E. We then look at what happens when they arrive in the A&E, and we work through with Dr. Cruickshank's team all those different steps and stages within the A&E, and there's a number of key steps and stages: triage, well, registration, triage, seeing the A&E doctor, paths and diagnostics, a specialty doctor, through to an admission. And each of those steps and stages have different demands and different needs. So we have to look at each one and understand what causes the delay there and what's causing that delay today. And we do that every day, every morning on a huddle. We all come together and we have a look. Some days it's people waiting for beds is a real priority, a real concern. Sometimes it's people waiting to see an ED doctor. So each time we have a look at what the challenge is, and then we work out through an escalation plan that we've developed what action will we automatically put in place to address that particular challenge. Often the challenge for the A&E won't necessarily be within the A&E department, it will be trying to move people out of the A&E into the beds. And as we alluded to before, we can have 40 to 50 patients in the hospital waiting to leave the hospital who are no longer acutely ill, and we can have 20 or 30 patients waiting in A&E to come up. If I could move those 40 or 50 out, those 20 or 30 in the A&E department would move out immediately into a bed. That would release space for the A&E team to see the patients, and it would allow the teams to move much faster and focus on those who should be in the A&E department, not those who are left in the A&E department to lodge. Now, to be really clear, when I say left to lodge, they're now being taken care of the specialty doctors in the A&E department. There's then what's a challenge on the specialty doctors looking after patients on the wards and in the A&E department, we have a similar thing then when they move into the wards. They arrive on a ward, what tests and diagnostics do they need? When do we expect they'll go home? How do we plan for them to go home? Will they need supported discharge when they go home? So we go through a range of different operational aspects, understanding what's happening with the patients on the ward. And we just introduced, just actually this week, what we call the Days of Care audit, where we're doing audits on patients, every single patient on a ward. What are they here for today? What should be happening to them now? And can we understand what we can do to move forward? And it tells us that about a third of the patients in the hospital probably don't need to be there. So there's the 40 patients that we've identified who we know, and we call them delayed discharges, not abandoned patients. It's a term that's a strange term because maybe a handful of them may have been abandoned by the families, but more often than not, the families need support to take them home. And even if those had been abandoned by the families, to move an elderly care patient back into a family who doesn't want them wouldn't be the right thing to do either. So we call them delayed discharges and how we manage those. But there's a group of other people who are in the hospital who, if we had the right services somewhere else, maybe we could move those out as well. And the aim of the audit is to capture that information, because we've been having meetings with the Minister and with the polyclinics and with the private sector indeed, to understand how can we provide some of the services that are happening for the patients in the hospital outside. So it's a whole journey that we go through, from trying to avoid them coming in. I always say prevention is cheaper than treatment, and it's obviously much better for the patients, to the A&E journey, to the inpatient journey, and in between that, the diagnostics and the lab journeys, to the discharge journey, to getting them back into the community safely, so they don't end up coming back in again in 2 weeks' time. Okay.
Well, Minister, back at you again. With this rising demand and with the suggestions made from the CEO, and you would have mentioned earlier about patients being left there as well, what policy level changes are in the works for strengthening the emergency healthcare services at the QEH?
Well, that's actually a great question. And let's start with the fact that emergency healthcare services are at the QEH, but as I said before, they don't start there. So right now what we're looking at is the entire ecosystem. So we're trying to work through what's happening in the communities. First of all, let's start there. So community nursing. How do we get more community nurses out into the community to be able to interact with persons in their homes and within their families to provide that kind of support? How do we get people, particularly those with recurring illnesses that they know, that will say to them, okay, well, I'm supposed to be on medication, I'm supposed to be doing this, but I'm not quite so sure what I'm supposed to do, and I don't want to go to the doctor all the time, so I'm just not going to do anything, and then I stay at home and get sick. So how do we help people in situ? How do we equip the polyclinics now? As you know, the government has announced under my predecessor, Senator Walcott, who was Minister of Health before I assumed the role, he initiated the rehabilitation and the new building of 9 of our polyclinics. 7 will be rehabilitated, 2 completely new builds. So now we're pursuing that. But building new infrastructure is one thing. Ensuring that the new infrastructure is fit for purpose is the main thing. And so what we're doing now is looking at what laboratory services need to be in those polyclinics that will make persons have access to x-rays, maybe CT scans, or those kinds of things, not having all of it come to the Queen Elizabeth Hospital. How do we work with private caregivers or persons who are in the private system to take some of the pressure, decant the system a little bit away from the Queen Elizabeth Hospital? So genuine cases of accidents or emergencies, or persons who are acutely ill in the categories that Dr. Cruickshank spoke about, are then those persons that come into the system. But then CEO raised the point about what do we do when a person is in the system. I'm sure you've heard instances where someone would say, and I've had it even before I was in this role, where someone says, my uncle, my brother, my son, he is sick, he's been in the hospital, he's diabetic, he's had an amputation or he's had something happen, and they're discharging him. I don't know what to do. My house isn't equipped for him. I don't know how to take him home. I don't know how to deal with his dressings. Can you intervene and ask them to keep him in the hospital? And that may last 2 days, 3 days, a week, a couple of weeks, and then the time can just go. How do we then help people to be more comfortable with taking their loved ones out of where they feel they're better cared for in a hospital, and get them back into their homes, into their communities with the support that they need? So step down care in communities and at homes for families is one of the things that at a policy level we're looking at. So it's the entire from start to finish and making a complete circle to support families, because really what this has to be about is the people at the center of the healthcare system. And that's where we're going now. Equally, we're looking at how we can partner with other institutions to be able to expand the suite of services that we currently offer, both in the primary care system outside of the Queen Elizabeth Hospital and then even internal to the Queen Elizabeth Hospital. And this is the final thing. CEO, we had this conversation last week. I went to the hospital one day and I walked through and I said, why are all these people in the downstairs area of the pharmacy? Even simple things like that we were talking about. The hospital dispenses medication for people when they're being discharged. So you're going home and you're happy to be able to go home. But half the times you have refills. And the medication dispensed by the Queen Elizabeth Hospital, you have to come back to the Queen Elizabeth Hospital if you have a refill 3 months, 6 months on a monthly basis to get that prescription filled. You can't fill that prescription as it currently stands at any polyclinic. So imagine if you live in St. Lucie. You can leave St. Lucie, you can pass the polyclinic in Maurice Byre, you can pass Branford Tate in Blackrock, you can pass Warren's, and you gotta come down to Martindale's Road. So even those kinds of systemic changes, we're now looking to make sure that we can take all of that traffic away from the Queen Elizabeth Hospital and allow people to benefit from care in situ.
Okay, what about these, within the services of the hospital itself, we would have heard persons talk about even after their discharge, which is the aim to get them back into society, resume normalcy. Persons speak about hours having to wait for their medication, or their prescription.
Exactly.
So then that's obviously
that's a huge issue.
Yeah.
And we saw it for firsthand. I've seen it there in person watching the patients, and I've had the opportunity to meet with the entire pharmacy staff in the Queen Elizabeth Hospital and to hear from their perspective how densely populated that area can be, and how from their perspective dealing with all of the medications can be very problematic. So it's something that we've met with the Barbados Drug Service now, who has responsibility for working with the polyclinics to see how we can have a system in place to address that. And I'm hoping that while we look at the big picture wins, new hospital, new polyclinics, all that stuff is big picture stuff, but what are the wins that we can give to people in the interim? And that's what we're focusing on a dual track. That particular issue is one of them.
Thank you.
And of course, in the interim, we do have the home delivery drug service.
Yeah.
Okay.
So those who are unable to get in, we can deliver to them.
Yeah.
Okay, good to know. We actually have a question coming in from the audience already. This one is from Suzette Thompwatt. Suzette Thompwatt. Is the actual capacity of A&E, or what is the actual capacity of A&E, and how often is it exceeded?
In terms of the number of patients we see a day?
I'm assuming.
We can see about 60 to 80 patients a day, and that is relatively okay for this staff. We would probably have about 5, 6, 8 doctors on a shift, also the nurses and other staff groupings. It is when we see, for example, on one shift, you're going into the 30s and the 40s, 50s, 60s. That exceeds our capacity. We can't manage. So we usually say we are now in an internal mass casualty within the A&E. You will hear about mass casualties outside, but we can call one inside the A&E. At that point, we have to set forward the escalation plan and put measures in place to deal with that.
If we can just perhaps interrogate that thought a little bit more. We talk about what is the capacity of A&E. I think Dr. Cruickshank spoke about the categories earlier, categories 1 through 5. So imagine you've come into the QEH, you are in a category 4 or a category 5. You are stable, the doctors have, the triage nurse has assessed you, you're okay there. And simultaneously, some youngsters decide that they're going to get trigger happy and there's a gunshot incident somewhere else. You don't see those persons coming in necessarily through the main entrance of the Queen Elizabeth Hospital. So you're frustrated because you're like, why can't I be seen? But you may have been triaged as category 4 or 5. But a gunshot wound comes in on the outside, and that's immediately going to come above you in terms of priority. Or a heart attack comes in an ambulance, or someone who's having some kind of emergency issue. We don't see that in the main entrance coming through, but that may be coming through in the ambulance. So immediately, the capacity is not just exceeded, not necessarily numerically, but by the nature of the emergency that has come in. So sometimes it's a little bit more nuanced than just numbers. I don't know if I'm Dr. Cook.
Yes, that is totally correct, Minister, because sometimes a gunshot wound would take all the doctors on duty to stabilize that patient, and the nurses also, because you have to stabilize them to get them up to the operating theatre, and the specialties also have to be called in. So everything for the regular patients, inverted commas, go on pause while we try to stabilize and save the life of that category 1 or category 2 patient to get them up to the operating theatre.
But then it may only be a matter then of communicating then with persons who are waiting or who may believe that they've been waiting for a very long time. Is there any type of liaison within the accident and emergency that shares that information?
So we have different staff groupings, and the grouping that we would use is the patient relation representative. They can be the one, they are the interface between the patients and the doctors and nurses inside the A&E, and they will be the one to explain to the patients as they make their rounds through the A&E what is happening, because patients want to know what is happening. Also too, when we have an influx of gunshots or stab wound, we have to lock down the A&E to protect the staff within, because we do not know what is happening in terms of who is coming after these gunshot patients arrive. We don't know if they want to finish them off and therefore put the staff at risk. So we lock down the A&E, and the police then will be addition to the security that we have, and only patients who are actually coming in will be allowed to come in. Family members will not be allowed to come in as we stabilize the number of patients that are now coming into the A&E, i.e. gunshots or stab wounds.
Okay.
And I think it's also just worth considering, we talk about the capacity of the A&E department and the number of spaces that you have to treat patients. But one thing that we've not been doing here at the QEH is monitoring how many's arriving by the hour. Now, A&E attendance is quite predictable. Sounds strange, but the unplanned attendance of A&E is quite predictable. We know by hour of day, roughly, how many patients we should be seeing. And therefore, we know if that particular hour of the day we see double the numbers, we know we're going to have a problem downstream. And therefore, we should be escalating upstream. And I think what we've done in the past traditionally is we've escalated when we're full. And what we should be escalating is when we're getting the numbers coming through. Now, that's all reliant on data and collecting information. And as you'll have heard, we are rolling out a health information system. And we do look forward to getting that into the A&E department to get real live data, giving real live triggers that actually the A&E department's being overwhelmed. For 2 hours on the trot now, it's seen double the number of patients that we would normally expect. Therefore, let's start bringing the additional teams and additional staff now. Let's do this internal major incident or surge planning. We start that now, because this problem is going to be coming to us in about 4 or 5 hours' time as the patients are working through the system.
Okay. We've been speaking about the rising demand, and you've just mentioned numbers and the importance of collecting data. Can you honestly share some information on the increase in the numbers and the cases presented at the QEH?
So we know that we've seen an 8% increase on the previous year of patients coming to A&E, which is about 175 patients extra every month. But in that 8% increase, what we saw was a 14% increase in what we call the category 2 patients. So those are just behind the category 1s, the resus, those who are seriously ill. So we're seeing an increase, but a bigger increase in the more seriously ill patients, which is good because that's where we want them to come. But of course we could rewind that and say, if we'd intervened earlier in primary care prevention, managing the blood pressure at an earlier stage, we could have maybe avoided the stroke, avoided the heart attack. So that's why Minister Cummins says it's a whole system approach. But yes, the numbers are going up. 175 extra patients a month are coming through the A&E department, and the biggest increase is in the category 2 patients.
Can we just camp out there for a second though, because when a patient comes into the A&E, and I've been reading the reports that have been submitted by the teams and listening to their explanations of the reports, when a patient comes into the A&E sicker, they have had an NCD, for example, which has been poorly managed in the community. They haven't gone for treatment in the primary care system, and so they present sicker to the emergency room. Let's say they're admitted to the hospital. What we're seeing is that we have the increases in arrivals, persons coming into the emergency room, but they're staying longer in the hospital on the ward. So they're being discharged after an extended period of time. And then afterwards, by the time they go back into their homes, they're repeating the same cycles. They're not necessarily improving their management, and it becomes a revolving door. And so they're coming back into the system again and repeating the cycle. So you've got frequent flyers, as you call it, sometimes with NCDs, and those things also impair the A&E's ability to just thin the density, because you've got persons who are coming in sicker and staying longer. So you may be able to turn people around in a shorter space of time, get them well again, get them back home with their families, but now they're staying in the hospitals longer. And so all of those are reasons that you will find the pressure. And let me just say up front, I hear the operational questions, I hear the process questions, I hear the standard questions, but at the end of the day, this is a people question. This is about families and this is about people. And so people simply want to be able to figure out how to be able to get through the system and not feel as though they're being made to feel worse. Can we do a better job perhaps of communicating at times? I'm sure that we can. Is there the need for additional patient care advocates so that we can then perhaps have more persons moving in and around the emergency room area to interface with family members to say what's happening? Maybe there's always room for improvement, and I would never say otherwise. And I think that's where our attention has been focused right now, looking at the whole of system approach, acknowledging the hard work that's being done already by the persons like Dr. Cruickshank's team, like Mr. Clark's team, who are already in the trenches and fighting it up every day, but also looking for the areas in which improvements can be found.
And I think it's worth adding, we mentioned that we've seen an acute in the category 2, the acute patients, but we don't leave behind the non-acute patients. So the category 4s, the category 5s, you have your minor illness, and you have your redirection to the polyclinic over the road. And maybe just to explain that, we will try and take, when we don't have a shooting on and the doctor's available, we will try and to maintain a minor illness and minor injuries unit to keep those low acuity ones, because if we can take those out of the system as well, again, it thins out the A&E department for them. And if you're sat there and you're waiting for hours and hours and hours, you don't know that you're necessarily low acuity. You think maybe that even the triage has got you wrong. So the sooner we can get anybody seen initially by the doctor, or we've even got the nurse practitioner to manage those patients, and we can give them a definitive answer to what their concerns are, and hopefully, because they're low acuity, discharge them home. That works well for us too.
Okay, thank you for that. We have a question coming in from K. Lewis. What real improvements can patients expect in the next 6 to 12 months? Thank you for your question.
So if I take that one?
You can start,
sure. I'll be brief. So we've got an improvement plan, and we shared the improvement plan with the Minister, which shows how we plan to tackle, in this particular area, the A&E waiting times. And we've got to say that we can expect to see improvements in the A&E over the next 6 to 12 months. We've seen very slight improvements already, but with the number of initiatives that we've got rolling out, both within the A&E department and within the wards, that are starting to take traction, we're going to see some movement, I have no doubt. We're always going to be stuck potentially with the front and the back door, where it's a little bit more overly complicated. The people coming in who we don't need to come in and helping them to move them out, that might take a little bit longer. But there's still what I call the low-hanging fruit within the hospital. There's still efficiencies that we can make within the hospital on how we manage patients through the wards. So are we sure that everybody's take-home drugs were ready the day before they went home? Are we sure that nobody waited for diagnostics for 2 or 3 days when they should have had them on the same day? So all those areas that we're trying to streamline and improve the flow for is something that we're working hard to do. That will no doubt bring us improvements, and that will then no doubt feed back to the A&E waiting times as well. So I've no doubt that we will be seeing improvements in the A&E waiting time over the next 6 to 12 months. Okay.
Anything to add to that?
I think that on the A&E specifically, the CEO has covered it quite well. Health system planning overall, we actually spent the entire day today with PAHO and the entire Ministry of Health team looking at a range of interventions on health system planning and improvements that are being rolled out, and you can expect to hear some updates on what those rollouts will look like in the number of areas. You'll hear us talking more about the preventative care. You'll hear us talking more about mother-to-child care. You'll hear us talking a bit more about elder care, how to look after our elderly in our communities. You'll hear us talking about things like climate and health. You'll hear us talking about, of course, the emergency care, and then you'll talk about health system integration planning. Those are some of the things that we're working through. We have an action plan going forward, and we'll share some more in time to come.
Thank you very much for that. So we're going to take a short break right now, but when we return, we'll continue the conversation and take a closer look at solutions to reduce pressure on the system and what the future holds for healthcare delivery in Barbados. Keep your questions coming in via YouTube and Facebook. We will be right back. Hi, I'm Sharifa, the host of In Focus, and along with my amazing team, once a month we produce and go live with our show In Focus, where we discuss topical issues around Barbados. We usually have a panel of experts, persons living in the particular experience. Sometimes we have government officials who can address the legislation side of it. And then we also get live feedback from the audience, from our Facebook and YouTube followers who may have questions, who may have concerns, or who may just need to drop a comment in, and then they can get a real-time answer from the panelists. It's an exciting experience. It's great learning more about different initiatives and programs in and around Barbados. And yes, that's it.
The line, stay inside and pay the easy way online with the Pace Digital mobile app. Now you can pay for your renewed license, police certificate of character, and more via the EasyPay Plus platform with the Pace Digital mobile app. Log into EasyPay Plus, select the service and confirm. Select the Pace Digital mobile app payment icon for your QR code. Open your Pace Digital mobile app and select the Pace Digital Pay tab. Scan the QR code and confirm your payment. Visit us online to learn more. Don't have the Pace Digital mobile app? Download it today.
Just a Conversation, the podcast where we discuss the topics that matter to you.
From real stories to real talk, we dive into everything. No filters, no fluff.
We're talking about the issues you actually care about. Finance, mental health, sports, entertainment, and so much more.
It's not just talk. It's conversations that bring us together, challenge us, and keep it real.
Don't have time to watch? No problem.
Just turn on the video while you're cooking and we'll keep you company.
Listen on your morning commute, while you work out at the gym, or even when you get home on evenings and chilling out.
Wherever you are, however you listen, this is your space for real conversations.
Join us.
Join us.
Just a Conversation.
Available on all streaming platforms or wherever you get your podcasts. Follow us on social media at GIS Barbados to share your thoughts or to stay connected.
If you've ever sat in the accident and emergency department at the Queen Elizabeth Hospital, worried, waiting, and wondering what happens next, then you know how stressful that experience can be. This week on In Focus, we examine emergency care delivery at the QEH, how the triage system affects wait times, what's driving increased demand on the A&E, and what steps are being taken to ease the pressure on that department, especially those seeking care. We'll also look at the role of the polyclinics, staffing challenges, and what the proposed expansion of the QEH could mean for patient care. Join us live on Tuesday at 8 p.m. on the BGIS YouTube channel and Facebook. And remember, we're taking your questions live during the program. So join the conversation and ask our panel anything in the chat. Follow GIS Barbados on Facebook and Instagram, or BGIS Conversations on Instagram to stay connected. I'm Sharifa Medford-Gilkes, and this is In Focus. Welcome back to In Focus, and for those of you just joining us, we're having an important discussion on emergency healthcare delivery at the Queen Elizabeth Hospital. We've been hearing from our panelists on the systems and challenges within the accident and emergency department, and we now have a lot of questions coming in from you, our audience, so let's get underway. Our first question is coming from Cameron Seeley, 6130. Are the doctors on duty authorized to advance the patient's care, or do they have to wait until senior doctors arrive the next morning?
Okay, so I'm assuming that they're asking about the specialties, because the A&E doctors are made up of senior doctors, and then we have junior doctors. So in the A&E, the junior doctors will see patients and they have to discuss the case with the senior doctor. But after that, they may have to refer the patient to a specialist, and therefore the specialist has to come down and see the patient. You find, especially for internal medicine, because a lot of the referrals are internal medicine referrals, the internal medicine doctors prefer to wait for their ward rounds in the morning when their consultant comes in, to go through all the referrals to decide if the patient needs to be admitted. And because internal medicine referrals are so many, sometimes the consultant does a night ward round and also comes back in the morning to do a morning ward round. So you may have 2 ward rounds with internal medicine, and the consultant will guide their specialty doctors if the person needs admission or if they can be treated and discharged and follow up in the outpatient clinic.
Okay, just for clarification, this is that treatment that happens in the accident and emergency for those patients who didn't get admitted to a ward yet?
Right, so they have to be seen first by the A&E doctor, then referred to the specialty, and then the specialty will decide if they need admission. If they then need admission, we have to then, bed management will come in and assign them to the respective ward for the respective specialty.
Okay, great,
yes.
Thanks for that. Our next question is coming from Skipper P. Will nurse practitioners help reduce wait time or patient care in accident and emergency?
Yes, so Mr. Clark alluded to nurse practitioners. We are very excited that our first nurse practitioner started last month, and we will have 2 more coming towards the end of the year. And we're very happy about that, because these nurse practitioners see patients. We give them the category 4 patients to see, and as Mr. Clark said, they're in the minor case unit. We have minor case unit, and we put the nurse practitioners there, and they will see the lesser acuity patient. That puts a load off the doctors now to focus on the categories 1, 2, and 3. And sometimes we ask them to see 3s. If the 3s are not too severe, the nurse practitioner can see the 3. So she's an integral part of the A&E team, and she's so excited to be learning new things, and we're looking forward to the other 2 joining and completing the team.
Okay, thank you. Next question is from Ian Park. Does the QEH provide post-care follow-up or any education post-treatment?
Okay, that would probably fall under the specialties, because the A&E doctor is the acuity doctor. We see, stabilize, and then refer. But the specialties on the ward have to then put into place in terms of educating the patient and the family members when they are discharged, how to manage the patient. As Minister said, that's very important. And because they feel not sure what to do, as Minister said, they want to stay in the hospital. But we want to empower them to know that we have services outside of the hospital, and that's where the social worker comes in. Each ward, including the A&E, has a social worker assigned to them, and the social worker will advise the patient and the family member of services that can assist them when they're discharged and put things in place. And then we have all the other team members in the hospital, that physiotherapy, occupational therapy, that can guide you to help that patient on discharge be ready for when they're discharged. So we do want to know when they're going to be discharged to tell the family member to start getting ready.
So that's a major area for improvement, and that's one of the things that we described earlier as step-down care, post-acute care, and that's one of the areas that we intend to be able to work on during this year. I believe you heard the government during the election talk about the introduction of a rehabilitation center, the introduction of hospice care in some instances. Those are priorities that we have here for this current development cycle, but we also have a partnership that we're evolving now with the private sector that does have step-down care, that goes into the households and deals with the patients and so on. How do we partner with them? Do we have the ability to be able to help people who have been bedridden for a moment because they've been hospitalized to have rehabilitation, physiotherapy, occupational therapy? We have one physical therapist in the entire polyclinic system who is there, and we need more of that. So we now need to be able to expand what happens in the cases when people have been discharged from the hospital to help family members and to help the patients. So that's actually an excellent question, and it's one of the things that we're now building into the system.
Okay, thank you for that. Our next question from Marcia A. Are all the operating theaters now working as scheduled, and is there still a backlog of persons awaiting surgeries?
CEO.
Yes, I can confirm all the theatres are back up and running. So we did have some problems with the theatres and the air handling units and the chillers, which keep the theatres cool. We had some problems fixing those. It took longer than what we would expected, but they're all back up and running now. Whilst the theatres were down, it did lead us to have a good review of, well, how do we use our theatres as efficiently and as effectively as possible. So like we did a piece of work with the A&E department, what's all the different steps and stages. We started that piece of work with the theatres. We created a new theatre committee, the new theatre users committee. We're in the process of publicising the new protocols for how we manage theatres to make sure we're using them as efficiently and as effectively as possible to get as many patients through that system as we can. One of the things I'm looking forward to again is the introduction of the health information system, which will allow us to capture and track all the patients in the system, where they're up to, how they're being scheduled to theatre, when they can expect to be scheduled into theatre. Because that's one of the questions, obviously, that we get from patients quite a lot. When will I be going to theatre? So to get the information centralised onto the health information system will make that really helpful for us to give them good information back as to when they can expect to be coming forward to have their surgeries.
This leads to another question that comes to mind. Does maintenance play an important role in the efficient functioning of the hospital?
Maintenance
of departments, of equipment.
Indeed. So we have an engineering department, but for many of the complex bits of equipment that we've got, the air handling units and the chillers, the air conditioning units and the theatres, which are giant units, not like you'd see in your house. These are giant units that need cranes to lift them into place. They tend to be serviced and maintained by external companies that we've contracted. So it's not just our engineering team, we've got specific experts on specific different elements to do that. We've got 17,000 pieces of equipment that our engineering, our biomedical team maintain across the hospital. But on top of that, then a 62-year-old building with the plumbing, the electrics, a flat concrete roof which isn't waterproof. We keep our engineering department very busy with maintenance.
So let's also consider the hospital. All of us have walked through the hospital in those corridors with those decoration blocks on one side, and you have the decoration blocks with a continuous flow of hot air coming in, and we know how AC works. You pull that constant flow of hot air coming into a facility with the kind of air conditioning needs that are required, you're going to have these continuous issues. And so the maintenance department, the engineering department has been working through what that looks like, and they've just done a significant body of work with the chillers, the duct work, putting in new AC units as well, but also to be able to address issues of condensation and so on as a result of what we were just discussing. So we now have 7 operating theatres up and running as of Monday this week. Today's what, Wednesday, Tuesday? Today's Tuesday.
Yes.
As of yesterday, we now have them up and running. So that means that we have a total of, is it 9?
9 theatres.
9 theatres that are now back into operation. And the ambition is to be in a position to have all of the operating theatres back into operation, including the ones in the Lions Eye Care Centre. Those are the last 3 that we're looking to earmark for full rehabilitation, including issues of the roof. So we're moving towards getting that backlog cleared. It may not happen overnight, but we're committed to moving it forward.
Great. Okay, we have another question coming in. This is from Shelly G, 3747. Are patients advised which category they are? Thanks for that question.
I think they are, but it's something we have to stress to the triage nurse that they should. Not all the triage nurses may tell the patient which category they are in. Our service improvement managers are trying to put some signage now in the A&E to prompt patients to ask their triage nurse, what category am I? And to let them know, what is happening to them. So they're not always said, but you are free to ask the triage nurse what category you are, and the triage nurse will explain that to you.
Okay. What if they are given the category, but in their mind, as you mentioned, they might not think this is not my category? How do we alleviate that fear and calm them, comfort them through the time?
Yes, we really have to just explain and educate them on the different categories and explain their category to them, because everybody thinks they're an emergency, but there are different categories of emergency, and your emergency may not be life or limb threatening, but to you it is. And I think it's just really calming them down, educating, explaining to them, and letting them know we're going to see you shortly, but we do have other persons which we need to see right away. And just keep on circling back and letting them know what is going on. Communication is the biggest problem we have, but that we have to fulfill that.
Okay, understood. Next question from Harry to the max. Is there a plan to increase the number of doctors assigned to a given shift in the A&E?
What can I say? Mr. Clark alluded to the fact, and Minister alluded to the fact that we do have a shortage of emergency physicians, right? But we have residents in training now, and we try to encourage the other junior doctors to work in the accident and emergency, because they also contribute to the management of the patient. When we do have, like, for example, the internal mass casualty, we have to bring in the residents who are rotating out of the A&E to come back in and help us. Mr. Clark is looking at all the emergency physicians that are trained in Barbados to see if they too will come back and give us sessions. So we have immediate, medium and long-term plans to bring emergency physicians back into the A&E to help us. And there's some of us who are still there committed, working tirelessly with patient care.
So I want to be very upfront about this. We have shortages. I think we have 6 vacancies presently in the accident and emergency department for doctors. We know that we have a shortage of nurses. So we've been working on the back end to be able to figure out what is the throughput. So from the University of the West Indies, we were just discussing before we came here tonight with the University of the West Indies what the output from UE is on an annual basis from their MBBS program. How do we get to meet the needs of the various specializations, whether it's emergency, it's urology, oncology, whatever the specializations are. But there is only so much that the university can put out, or in the case of nurses, the Barbados Community College can put out. So we have to begin the process of recruiting and bring those persons in from other jurisdictions. And we started to do that. We've seen nurses come in from other places across the world, and equally so, we are expecting that we're going to have to bring in some doctors in the short term to be able to fill the immediate needs that we're seeing in places like the emergency room, but in places like hematology. One of the things that Anne-Marie, when she spoke about medium, short, and long term, we're also looking at how many specializations do we have. Barbadians know B2. So we know what B2 is a specialization for. We know when people are in labor, which ward they're on. We know where the cancer wards are. So that's what we mean when we talk about the specializations and the wards, right? So how do we identify how many persons are in the system, been in the system, committed, nearing retirement, how do we put succession planning in place? How do we match that with what's coming out of the University of the West Indies? Let's amortize that over the number of years and then figure out where the gaps are. So all of those, again, going back to that ecosystem, that whole health system planning that we are undertaking right now.
Okay, thank you for that. Our next question is coming from, I don't want to get this wrong, Asieta Small 5139. I'm wondering about the impact of diagnostics, timely tests and results on patient flow in the A&E and flow in general.
Yes, the timely results of diagnostic, i.e. blood results, and radiology, i.e. imaging results, are very important in the patient's flow. Patient's flow is divided into input, throughput, and output, and it's the throughput is where they're waiting for their results. We've put some measures in place where, for example, for radiology now, we have teleradiology, where from 8 to 4, we have the local radiologist reporting on all the investigations. But from 4 p.m. to 8 in the morning, we outsource our radiology. So we have a team in India, and we communicate to them with our cell phones. We have a teleradiology phone, and we will tell them which patients we're waiting for reports, and they will send us the report. That has helped us tremendously in getting back our reports in a timely manner, because specialties need their reports. Similarly, for the blood results, we're trying to work on an electronic system to order the blood results quicker as opposed to writing the forms. So we're now working through some challenges with that. By getting your diagnostics back quicker, you can refer to your specialties. They can come and see their patients quicker and make a definitive diagnosis and decide if they need to admit or not. So diagnostics play a very important part in the flow of the patients through the system.
Let's consider, we never had a CT scan machine, for example, before in the A&E. We have one now. It's now being finalized for setup. We're waiting one part to come in, but having that facility on the ground in the A&E is a huge improvement in getting the results in. And so we have to be able to see the wins and claim the wins even as we move towards getting other things done at the same time.
Thank you. Next question, we have, this one is from Pilar Barrow, 9608. This message is for the Ministry of Health. What measures are being put in place with regard to primary care to help ease the strain on the A&E?
That's a huge question and an important issue. We're now working through with all of the polyclinics. We have now created a grouping of all of the polyclinics led by the ministers, what we call the medical officers of health. They have all put forward performance improvement plans and reform and transformation plans for each polyclinic around the country. We've also looked at the district hospitals around the country, and then we have the outpatient clinics. So we have all of these facilities around the country now being in a position to say, here is what our optimum future state would look like. And then we amortize that year on year on year. So year 1, which is now, what are the improvements that we're looking for? Year 2, what are the improvements that we're looking for, until we get to a state where the patients and their families feel as though they are being able to benefit from the standard of care that they deserve, and that the doctors and the nurses and all the staff that work in the facilities feel as though they're delivering and giving of their best because the system has been constructed to work in their favor. And so that's what we're working on now, and we already have those draft plans for each one. We have asked the Pan American Health Organization for assistance in health integration, because one of the things, and the CEO mentioned, for example, the health information system, that's a huge deal. So many people originate in the primary healthcare system, in the polyclinic system. Do I have access to my notes when I go into the Queen Elizabeth Hospital, so that the doctor in the Queen Elizabeth Hospital is able to see what they were treating me for in the primary healthcare system? All of those things are that's what we're working on now to be able to deliver for Barbadians.
Okay, thank you. Our next question is from Marita Marshall. Is any consideration being given to include physiotherapists in the A&E triage system? Thank you for that, Marita.
At one point in time, the Department of Rehabilitation was sending down a physiotherapist to help the social cases, i.e. the elderly, for care. and they were being sent, and they were actually with the team coming down and doing physiotherapy for the elderly for care. Unfortunately, it's not a consistent program. We don't see them all the time. We actually will have to send up a form and request the physiotherapist to come down and help us with the elderly for care. But yes, the physiotherapists are included in the management of the elderly for care that are in the A&E, and we do have a few elderly for care in the A&E, which ideally they shouldn't be in an acute care setting, and we do have to care for them and treat them and do all their daily activities to assist them until they get placed at the geriatric or the district hospitals.
Okay, thank you. We have another question from Aiden's Bubble 4247. Can the nurse practitioners go to polyclinics and into the community, as it would reduce the amount of people coming into the A&E? Do we have legislation for them as well?
That's the intention. We have met with the Barbados Community College, and we have met with the principal nursing officer, the chief nursing officer in the Ministry of Health, and the intention is to be able to increase the number of nursing educators so we can produce more nurses and more nurse practitioners, and to be able to expand their utilization at the community level in the polyclinics, for the exact reason that the person who sent the question in is asking about. If we can decant and we can minimize the traffic coming into the A&E by treating to those persons with nurse practitioners in the polyclinics and in the communities, that's what we also want to be able to do.
So is it possible that the polyclinics will not be moving to maybe a 24-hour system or longer hours?
The intention is to have a select number of polyclinics 24 hours. What we've started to look at is how many persons are likely to go through the 24-hour system. So Winston Scott, for example, was meant to be the first one 24 hours. But you see that persons typically trickle off after a certain time. And so do you need to have a 24-hour facility to be able to see one person or two people? And so once we have a fully assessed data set that allows us to figure out, okay, so here's where they need to go, then we'll be in a position to make some final decisions, even though what is proposed is for there to be that select number of 24-hour polyclinics that will take that pressure off of A&E.
Is it possible, because you would have mentioned earlier about the faith and trust people have in the QEH in itself, is it possible that they trickle off because once again they veer back to QEH because of the trust that they have in that department?
Because you think about it and you say, well, you know, I feel as though I'm going to need an x-ray. I might as well go to QE one time. I might as well go to casualty, as we used to call it back in the day, one time. I don't mind saying, waiting there rather than having to go from one place to the other. And so people opt then to come into the Queen Elizabeth Hospital because the services are not available in the polyclinics. And so even in the existing polyclinics, I have visited at least 2, maybe 3 polyclinics where I can see the infrastructure is there. The walls are there thicker where there used to be radiology equipment, but it's not been there for a very long time. So in this rehabilitation now, the expectation is that the polyclinics will be, not all of them, but several of them will be fully equipped that will allow for the necessary triage services, including radiology, to be in those places. We currently have blood work in all of the polyclinics, so you can do that there, but then you still have to have the testing. So all of those things are anticipated in the rollout of the brand new polyclinics.
Any short term, or is this a long term?
Well, I would probably have to say in the longer term, but we are working on the logistics of what happens in the interim, because people aren't going to stop being sick because you're building a new polyclinic or rehabilitating an old one, right? So we have been working with, we've worked with one of our development partners to identify a health logistician to help us work through what are the logistics of the transition period between a completely newly done polyclinic system and what happens in the interim. How do we serve people in the interim? And that's where we're focusing on now.
Okay, thank you. We have another question from K. Ward. What about offering scholarships for the specialty areas to boost staff complements?
I can try to answer that. We have scholarships. We have Barbados scholarships. We have National Development scholarships. Here at the university in Barbados, University of the West Indies, we have the DM specialization where the fees are waived for the persons taking that to be able to have these specialties coming forward. The persons coming through the system aren't necessarily the problem. but we still live in a country of choice, right? And people will decide what works best for them. Some people may decide, I'm going to specialize and I'm going to go and take the highest offer in a university hospital overseas. Some may decide, I have a great opportunity for training and exposure in another institution overseas. Some may decide, I prefer to work in the private sector and I don't want to come and work in the Queen Elizabeth Hospital. So scholarships are not really the problem. It's that you can't always attract or guarantee that having offered the scholarships, that these persons are going to come back into the system to work in the hospital.
Speaking of these specialty areas, I know we have private doctors in these particular areas, and you would have mentioned partnerships with other organizations. Is it possible then that maybe the hospital could partner with some of these private institutions? I know it's going to be costly for the patient, but then maybe there could be some kind of subsidization or something that they could, send patients there instead of having them wait at the QEH.
Yeah, so at the moment, I mean, Dr. Cruickshank will often sessional work out. So she'll work with private doctors in the private clinics, A&E doctors, and say, we need some support. Can you come and give us that support? And you get that from a number of them already.
Yes, so we do have sessional emergency physicians who, although they work in the urgent cares, they also come and help us. So they will do sessions throughout the day and they complement the number of doctors that we have that are full-time. And they really play an important role because they're all senior doctors. So therefore they can help with triage. They can assist the triage nurse in terms of assigning acuity scale. They can work in the minor case unit and see the minor cases. They can even see category 3s in the minor cases. So they play an important role in the management of the patients, and they do help us tremendously.
And that's not just in A&E, that's in other specialty areas too.
Mm-hmm.
Okay, well, we have a lot of more questions, but we have time for one more. And this is from Ian Park. What measures does the A&E have in place to track down relatives who abandon their relatives at the QEH?
No, that's not an A&E question.
As I mentioned before, we have an A&E social worker. So as soon as the elderly person comes into A&E, they usually come with a medical condition. They are treated, they are stabilized, and they're ready for discharge. It is when they're ready for discharge and we call the family member to come and collect them is when we have the problem. So that is when we now involve the A&E social worker to investigate the case. She will contact the family member. She may even have to do a home visit to see where the elderly person was living, if it is adequate. She will try to encourage the family member to take the patient back and will help them get services in the community in terms of home help, companion help. They may need help with their pension. The A&E social worker will do all that. If after all those things and there's no traction to take back the patient, the A&E social worker will then say the person has to be referred to the geriatric hospital. We then will we fill out a form. We will do a medical form for the patient, and we will then put forward a case to the geriatric. The geriatric helps us tremendously. Right? And every week we send a report to them outlining all the elderly for care that are in A&E, and they will tell us who they can take. Sometimes they can't take any females, they may have space for males. It depends what is happening, but every week the report of all the elderly go to the geriatric, and then they will tell us what can happen. Sometimes the district hospital, St. Lucie District Hospital, they can assist us with placement. But unfortunately, we are still, as we smile, as soon as we get one transferred, another one comes through the door. So we tend to remain at the same number, and the A&E is not suited for elderly patients. So we do try to encourage the family member to take them back with assistance, but if they say that they can't, we have to transfer them to the geriatric hospital.
The CEO should probably weigh in because it's a broader issue than A&E as well.
Yeah, so we mentioned earlier we tend to have 40 to 50 patients, and they're not all elderly for care. Some of them are young for care, which becomes even a bigger challenge. Absolutely. Because then we don't have a geriatric hospital for the young for care. So we provide this list every week. We update the list and we're sharing it daily, but every week we update the list. 40 to 50 patients will be waiting to move out of the hospital. A number of those will be in the A&E department, a number will be on the different wards. In addition to those who are waiting to move out, we're also tracking the ones who will become a challenge for us, because we know already from that they've come in maybe from a home that's not going to accept them back. The social workers have already worked with them, so we can maybe track. There's often between 15 and 20 that we know when they are medically stable for transfer or discharge, there will be nowhere for them to go. And this is why it's really important then that we work together as a whole system to say, well, how do we manage these people and what is it they need? And we talked about the term abandoned, but what support does that patient need to be able to go home? And would the family accept them back home then if somebody was going to come and maybe help get them up in the morning, help make the lunch because they're at work? So what support do they need? And is it social care and is it health care? Is it a residential space or is it a home care space? Is it a hospice space? So the whole range of areas that they're waiting to move into is what we need to be working on together and address this and move these patients to a more appropriate setting than where they currently are. And the A&E ones are a real concern for me because then they're blocking the space for the next emergency care patient. Exactly. And we have the debate each day. Yep. Do we move them from the A&E up onto the ward, which means an acute patient can't get the ward bed? And these are the daily discussions that we're trying to balance out as to how do we manage these patients and make sure that the right person, the right patient is in the right place.
Let's be clear though, it's not just elderly, because you could have persons who are, you're trying to figure out if you should move them into the geriatric hospital or into a children's home or in a young person. So it could be all age ranges, and when in the last reports you can see all age ranges in there. And so the question is always going to be, how do we get these people back into their homes, whether they be children, young adults, or persons in the elderly community. All of them are in the Queen Elizabeth Hospital at times when they do not need to be there.
So safe discharge is our number one priority. To safely put somebody back in an appropriate place, ideally their home with the support is the number one, but if not, then we need to make sure that we've got the hospice or the nursing home or the residential home to take them in.
Yeah.
Okay. Well, we're coming to the end now, so I'll ask each of you for your final comments, those final words that you would like the members, our viewers, and those who may be seeking care at the Queen Elizabeth Hospital at the moment to go away with, you know, as we go forward in the development of the QEH.
I would just like to say that the staff in the A&E are committed to taking care of the patients. I know sometimes we may have a few challenges, but at the end of the day, the staff do come to work hard and to take care of the patients as the best that they can. And it is not easy, but they give of their best every day.
Thank you. I'm going to leave you for last, Minister. Mr. Clark.
So I just want to say we're on a journey. And we wrote a strategy last year, and that strategy has within it A&E, but a lot of other things are in there as well. The digitisation is one very exciting thing that's coming along. So we're on this journey, and this journey started. We've got our public town hall coming up, I think, in 3 weeks' time. So we'll be going back out to the public saying, we said we were going to do this, here's how far we got. It's a 3-year plan, year one's now complete, and we need to show that progress because we need to be accountable to the public for the services that we deliver. And I'd just also like to reiterate what Dr. Cruickshank said. The vast majority of people I come across in the QEH are so passionate about trying to get this right. They know it's not right, and it's not their fault. It's a system issue, not a person issue, and they're very passionate about the changes that are coming. So I am sure we're on the cusp of some good changes for the QEH and to make the staff who work there proud to work at the QEH, and to make the public of Barbados proud of the Queen Elizabeth Hospital.
Thank you. Minister Cummins.
So for me, I could talk about health system planning, I could talk about integrated system planning, I could talk about polyclinic sector reform, primary health care, tertiary health care. I could talk about all of those things. But at the center of this, what I want this assignment to be for me is meeting people where they are in their families, where they are in the moment where they're ill, because they're not coming to us when they're well. They're not coming to the Queen Elizabeth Hospital on a day when they're feeling up and chirpy and said they want to go to the beach. They're coming when they're really at their lowest and they feel as though they need help. We need to be able to deliver for Barbadians once and for all. A lot has been done. A lot of investments have been made. A lot of infrastructure has been planned and delivered. But we have to make sure that the people who walk through every single door that we have available to us, whether it is a polyclinic, a district hospital, the Queen Elizabeth Hospital, that people feel seen, people feel heard, and they get the benefit of treatment that they deserve and need at any given time. That's going to be my focus. So all of the systems, the data, there are real numbers for people behind all of that. And I want to make sure that all of those people are accounted for in how we treat them.
Thank you for that. Well, tonight's discussion on emergency care at the Queen Elizabeth Hospital highlighted not only the challenges facing our healthcare system, but also the measures being implemented to improve efficiency, reduce waiting times, and deliver better patient care. I'd like to thank our panelists for sharing their insights and helping to bring clarity to such an important matter. And of course, thank you, our viewers, for your thoughtful questions and active participation. I know you have many, many more questions, and I'm sure that our panelists and their team will be happy to address them. So just send your queries and concerns to the email address provided below. And if you missed any part of tonight's program, you can watch the full discussion again on the BGIS YouTube channel and Facebook page. I'm Sharifa Medford-Gilkes. Join us next time for another topical and informative discussion on In Focus.